Thanks everyone for joining us. I think we recognise some of the names on the call. So if you're a returner, thank you so much for coming to our webinars again. My name is Sarah Jane Ryan. I co-chair the South East Coast region of the CSP, regional network of the CSP. And I'm joined on our call tonight with Claire and Amelia from the CSP and Fiona and Alice, who are doing this webinar tonight. As you know, we're based in the Southeast, but we are very much welcoming from across the 4 regions. So thank you if you've joined us from outside the Southeast. Just to let you know, the webinar will be recorded and all of our previous webinar recordings are on our Southeast regional page. So we've had really interesting webinars over the last couple of months, focusing on MSK, on cardio-resp. Alice did one on neuro as well, and we had a general one about interviews and kind of interview prep. So do take a look if you didn't manage to find or attend those previous ones. We'll be using both the chat and the Q&A function tonight. So if you have burning questions as you listen to Fiona and Alice, pop it in the Q&A, which will be on the top of your Teams link that you can see tonight. And Fiona will be asking you questions as you go along, so if you can use the chat function for those, so just for a bit of interaction. We do have you all muted. I'm sorry, that's just for managing a bigger group of people so that we can keep to time, but please do use the Q&A function and chat function as needed. And the recording will be put up afterwards in the next kind of couple of days. Early next week we'll get the recording up for any of you who want to kind of have a listen again. We will have some further information in terms of how the CSP will be supporting you moving forward at the end. So please do hang around for that if you're interested in hearing more. Over to you, Fiona. Thank you.
Thank you. Hi, everyone. It's great to be here and thanks for joining us. So this is a presentation about answering an interview question about Parkinson's. So I'll just introduce myself. So I've been in the NHS since 2007 and I'm a neurophysio. I've always had an interest in Parkinson's, and last year I was the South East clinical lead for the Parkinson's Excellence Network. And I've worked in community neuro for a long time, but I've just recently started a new project, which is the Restart PD project at Queen Square, which is exercise for Parkinson's through augmented reality glasses. So if anyone wants to know more about that, just get in touch. And I've also got helping me out tonight, Alice. So do you want to just quickly say hello, Alice?
Hi there, everyone. Thanks for joining us. I am a private neurophysio, so I work in the community with patients, and I have been a neurophysio since 2001. So got a bit of experience under my belt, so I'm here to help Fiona along with her talk tonight.
Thank you, Alice. So Alice will be keeping an eye on the chat and will let me know your answers to the questions that we're going to have later on. So what we're going to do this evening, a very brief recap of Parkinson's and what it is, an example of a real life interview question about Parkinson's, and then an example answer. And this answer will break down a bit of what you do for your treatment approach and what evidence and outcome measures you might use for working with someone with Parkinson's. So a very quick bit of brain anatomy. So Parkinson's affects the part of the brain called the basal ganglia, and there's a small part of the basal ganglia called the substantia nigra, which produces dopamine, which is a neurotransmitter. So what happens in Parkinson's is there's progressive degeneration of the neurons in the substantia nigra, which produces dopamine production. So over time, once the brain gets to the point where it doesn't have enough dopamine to control movement, that's when the motor symptoms will start to appear. And that's when people usually start to get their diagnosis. Very quick breakdown of the types of Parkinson's. So the main type of Parkinson's is idiopathic Parkinson's, and that's the most common form of Parkinson's. And it's called idiopathic because the cause is unknown, although we do know a bit more about risk factors these days, and there's lots of research into possible causes of Parkinson's. So for the sake of this evening's topic, we are mainly talking about idiopathic Parkinson's, but just to briefly explain other conditions that come under the same sort of umbrella. So there's 3 other conditions that are very similar that are called usually called atypical Parkinsonian symptoms, or sometimes you might see them described as Parkinson's plus. And that is corticobasal degeneration, progressive supranuclear palsy, and multi-systems atrophy. So all of these can cause deficiency in dopamine in a similar way to Parkinson's, and they all have some symptoms that overlap with Parkinson's, but they have a different progression to Parkinson's. So sometimes someone might initially be diagnosed with idiopathic Parkinson's, but when their symptoms follow a different sort of progression, or they're progressing quicker than they would expect, and they might question one of these diagnoses. And the atypical Parkinson's sometimes respond to dopamine medications, but they usually don't respond as well as idiopathic Parkinson's to levodopa, which is one of the sort of signs that it might be something else. So we could go into a lot of detail about those, but that's a sort of just quick description so that you know if you see a patient described as having atypical or Parkinson's plus or PSP, it just gives you an idea of what we're talking about. And just to give you some context on how rare those things are, I have worked in community neuro for a long time, and I've seen many people with idiopathic Parkinson's, but I've only seen 1 or 2 people with MSA, about 4 or 5 people with PSP, and only 2 people with CBD, so they're quite rare. And some other associated terms that you might hear as well. So Parkinsonisms is an umbrella term to cover a range of conditions that share symptoms similar to Parkinson's. They might present similar to Parkinson's. And vascular Parkinsonism is Parkinson's type symptoms in people whose blood supply to their brain is limited. So it might be due to a stroke or a small vessel disease. And again, one of the sort of diagnosing factors might be that they don't respond as well to medication. Dementia with Lewy bodies is a type of dementia that shares similar symptoms, but you could also have someone who already has Parkinson's that then also develops dementia. And then secondary Parkinsonisms that are as a result of something else. So, for example, I have had a patient who had Parkinsonism, drug-induced Parkinsonisms as a result of having lithium therapy for mental health problems. Her dose was too high, and then that resulted in lithium toxicity, which then led to Parkinsonism. So there's Parkinsonism is that general term of the symptoms that are similar to Parkinson's, but they're caused by something else. And this is a quick description of the main types of medications that you might see. There's many.
Oh, I think you've muted yourself, Fiona.
Oh, thank you. I don't know how that happened. Can you hear me now?
Yeah, all good.
Thanks. Okay, so this is a quick description of the 4 main types of medications you might see with someone with Parkinson's. There are other types as well, but these are the main ones that you'd see. So the main one is levodopa, and that is a chemical that converts into dopamine in the brain. And then there's dopamine agonists, and they mimic the way that dopamine works in the brain. So you might see them written down as pramipexole, ropinirole, or rotigotine. COMT inhibitors extend the effect of levodopa. So where someone gets on and off phases, so they might get over time where their symptoms are well controlled while they're on, but then their symptoms start to come back as the levodopa wears off. And COMT inhibitors is one of the things that might be tried to help with the wearing off. And then the MAOB inhibitors block the enzyme that breaks down dopamine. And it can be used alone early in the disease or added in addition to levodopa later on. And then just a quick mention of other treatments. So you probably heard of deep brain stimulation, DBS, and there's also infusion therapies. So there's an intestinal infusion via a PEG tube or a subcutaneous infusion that's attached onto the skin. So those therapies might be looked at later on if someone is getting to the point where they're oral medication. Oh, I'm getting an echo. Oh, it's stopped now. So that might be used if their oral medications are not controlling their symptoms very well, or they're really struggling with on and off phases. And then there's the way we describe the sort of stages of Parkinson's. I thought I'd just have a quick mention. So we talk about there's sort of two ways that we talk about it, either these sort of 4 stages of Parkinson or the Hone and Yar scale, which I'll talk about on the next slide. So we talk about the diagnostic, maintenance, complex and advanced stage. And then we also, in the early stages, talk about the preclinical or the prodromal phase. So that's before someone gets their diagnosis, but they're starting to get some symptoms. And there's much more research going on these days to look at whether there are sort of signs during the prodromal phase that might help to diagnose people sooner, or tell us what the more of what the risk factors are for developing Parkinson's. And then Hone and Yar scale is a way of describing the progression of Parkinson's. So you might see a patient, in patient's notes, they might be described as Hone and Yar 3 or Hone and Yar 2. So it just gives you an idea of where they are in the progression of their Parkinson's. And this is a quick quote from Parkinson's UK. They say, "We call it Parkinson's. We don't use the word disease because some people with Parkinson's have told us that it sounds negative or like an infectious illness. So it's not necessarily wrong to call it Parkinson's disease because many people still do, and most researchers and a lot of people, medical people still call it Parkinson's disease. But it's just something to bear in mind when you're talking to a patient. They might prefer you to call it Parkinson's." Okay, so this is the example interview question that we're going to have a look at. And this is a real life interview question that I was asked in an interview. And I think it's a really good one that breaks down lots of the things that you might need to know. And it's a nice way of breaking down a question. So I thought this would be a good one to start with. And it's a good example of a long question where they break it down into 2 parts. So this was a question in 2 parts. So A was describe some of the common issues in Parkinson's and what you do to manage them. And then B, discuss some of the key evidence to support your approach and how you measure the outcome of your input. So we're going to break this down and have a look at both parts, and we're going to get you guys to interact and offer some answers as well. So we're going to look at part A, describe some of the common issues in Parkinson's and what you do to manage them. So a question for you guys, and put your answers in the chat. What are some of the common symptoms or common issues that you might see in someone with Parkinson's? So just quickly type your answers in the chat, and then Alice will have a look at them and read them out. So we're just going to give you a couple of minutes to have a think about that and type anything you can think of in the chat, and just have a think about what symptoms you might have seen or that you know of that might be common in Parkinson's.
Great. So we've got some good answers coming in already.
Great.
Tremors, rigidity, shuffling gait.
Yeah.
Festination.
Yeah.
Bradykinesia. This is all brilliant, guys. Keep it coming.
You guys are really on it.
That's fantastic. Freezing in doorways. Yeah, that's a very common symptom that we see. Impaired balance. Absolutely. Posture instability. Flexed posture. Yeah, that's great. Oh, somebody's mentioned constipation. That's very good.
Oh, yes. Nice.
Yeah.
People are thinking about the non-motor symptoms as well. That's great.
Masked facial expression. Yeah, that's a very good one. And I really like that someone's put cognitive changes in as well, because that massively impacts our interventions. Yeah, you're doing brilliantly. Vocal changes. Yeah, people tend to get a little bit quieter in their voice. Keep them coming. Doing really good. Sleep disorders. Yeah, that's often something you see quite early on, that people's sleep gets a little bit disturbed. Depression. Yeah, absolutely. Yeah, quite commonly we see some mental health issues coming in. Doing really well. Any more? So obviously as physios, we tend to focus on the more physical symptoms, but like you quite rightly have identified, we do sometimes pick up on those non-motor symptoms that we see early on. And if we can get that diagnosis earlier, then that really helps us as physios to get that intervention going quickly. Yeah, eating and drinking issues, swallowing issues. Yeah, sometimes. Doing very well. Oh, we're after our 2 minutes. Shall I pass you back, Fiona?
Great. That's great, guys. You've come up with loads then. You've mentioned most of the things that I've put on the next slide. So, common issues in Parkinson's. So you probably have heard the statistic that there's something like over 40 possible symptoms of Parkinson's, and everybody is slightly different. So these are some of the common ones, but there are many, many possible symptoms. So the motor symptoms might be smaller handwriting, tremor, like you said, slow movement and bradykinesia. And also someone mentioned freezing of gait, so people getting stuck in doorways and things like that. Shuffling gait or festinating gait. So that festinating gait is where you either get stuck and then you speed up to compensate for it, or where your upper body's moving forwards, and then to compensate for that, you're shuffling forwards really quickly. Stiffness and rigidity, loss of facial expression, like you said, mask-like expression, risk of falls and dizziness, muscle cramps and spasms, and postural changes. So someone said about flexed posture. And then there's lots of non-motor symptoms as well. So fatigue, low blood pressure. So people can be more at risk of postural hypotension. That's partly because of the effect of Parkinson's, but it can also be because of their medication. So it's something to look out for. Bladder and bowel problems. So someone mentioned constipation. That's great. Sleep disturbance, speech problems. So their speech might get much quieter. Could get swallow problems, pain, and thinking and memory changes. So cognitive changes. And just a mention of mental health. So I think someone said something about mental health, didn't they? So someone with Parkinson's can be prone to depression and anxiety, and they can experience apathy as well. And it's important to note that apathy could be due to the dopamine deficiency in the brain. So it's not necessarily that someone's not engaged in physio. They might be experiencing apathy or depression as a result of their Parkinson's. And another important thing to think about is that, I mentioned the on and off phases with medication. So if someone's on an off phase from their medication, they might feel much more vulnerable and much more anxious. So it's just something to bear in mind for your timing when you're seeing patients. And then some things to think about with your communication. So someone might talk quietly, like we said, and they may take more time to respond. So they might take more time to process what you've asked them and to think of a response. So make sure you're giving people plenty of time, and they might not have much facial expression or much body language. So if someone is sitting very still and very quietly, and they're not very animated, and they don't have much facial expression, again, it's not necessarily because they're not engaged with you. It might be because they're struggling to communicate. So important to take your time and give someone plenty of time. So now on to some physiotherapy techniques that you might use with someone with Parkinson's. So there's lots of strategies that we might use. Task-specific training, so thinking about the tasks that are important to them and what they want to work on. Visual and verbal cueing strategies, so using prompts. So if someone's struggling to step or to turn, you can give them a verbal prompt. So a nice loud, clear verbal prompt will help someone. And visual cueing as well, so having something to step over sometimes helps. Rhythm, music and dance. So rhythm can really help. So using a metronome or music or stepping or counting. Dual task training, so training to do two things at the same time. Strength and conditioning to keep someone strong and functional as long as possible. Posture, like we said, you're more likely to get postural changes, so postural exercises are important. Hydrotherapy can help. I just mentioned there awareness of medication routines, like I said. So you might, if you're doing exercise with a patient, you might want to do that on their on phase and time that with when their medications are most effective. So ask them when's their best time of day. If you're looking at function and their ability to get out of bed, or where they're struggling with carers and things like that, you might want to see them when they're off at different times of day. Amplitude-based training is quite a big thing at the moment. So there's a company called LSVT Big, and their sort of form of exercise is training to increase the size, amplitude of the person's movement. So where someone's movement's got smaller with Parkinson's, they do exercises to make their movement much bigger and to sort of recalibrate the size of what they're doing. And PD Warrior, you might have heard of. So that's a circuit-based exercise class. It's high intensity, high effort, high amplitude exercise. So again, trying to increase someone's movement, and also as I'll come to later on when we talk about evidence, there is starting to be some evidence that high intensity exercise helps with Parkinson's. And then some strategies that you might use to help with freezing of gait. So we said about external cues, so visual cues, auditory cues and tactile cues. Weight shifting, so if someone's stuck on the spot, they can practice shifting weight from one foot to the other. They might shift their weight onto their good leg to then try and step their other foot forwards. It can help to visualize or imagine what they're trying to do. So if you're trying to step through a doorway, imagine stepping over that threshold and see yourself doing it, and then visualize each part of the movement. Practice in areas where freezing often happens, and it's also good to practice at a time when they're feeling well and they're good and they're on their medication, so that they're prepared for how they might deal with it at other times of the day. So you might choose to go and practice in that doorway or that threshold where they struggle with freezing. And looking at their environment modification, so removing clutter, make sure it's well lit, and modify pathways. So where they can have wider pathways or wider doorways to be able to get through easier. And then devices and aids. So there's lots of technology out there, and there's some aids that you can use that, for example, will vibrate and buzz to give you a prompt to step. And there's also walking aids and walking sticks that people can get that project a red line in front of them that they can then step over. So it's a external visual cue. And I just wanted to mention physiotherapy in the complex and palliative stages of Parkinson's. So, because we talk a lot about exercise in Parkinson's, but it's really important to think about all the other things that we do as physios as well, especially during the more complex stages. So when someone is spending more time at home and then getting to the stage where they're chair-bound or bed-bound, one of the most important things is falls. So you're probably, hopefully, familiar with your multifactorial risk assessment. And it's really important with someone with Parkinson's that you're checking their lying and standing blood pressure, so that you're looking out for that postural hypotension. And then we're focusing on managing any risks, and especially things like medication. So if they haven't had their medications reviewed for a long time, or if they do have a postural drop, it's important that you're liaising with their doctor to look at anything that's possibly reversible or manageable, and then training to get up off the floor, as well as decreasing the risk of falling. Still looking at posture in that stage. You might be looking at appropriate walking aids. So quite often we'll be looking at wheeled walkers for someone with Parkinson's. And then their functions, how they're getting in that bed, in and out of their chair, how they're managing with their activities of daily living. And that's when they might need equipment as well to help with that. And task-specific training, like I mentioned earlier, and goal setting. So it's important to ask the question, ask the patient, what is important to you? So one example, I had a patient recently who's quite late stage Parkinson's and was pretty much bedbound. And I said to him, what's important to you, or is there anything you want to be able to do? And he said, I really, really love gardening. So I worked with the occupational therapist, and we worked with him and his family, who he had a lovely family who built him a sort of waist high flower bed in his garden. So I was a planter. So he got to the point where he could transfer with a Sarah Steady into his wheelchair, and then could go out in the garden and do his gardening. So gone from bedbound to being able to go outdoors. So for someone who's in the later stages, little things like that can be really important for quality of life. And then later stages, when someone's bedbound, we're doing things to prevent pressure sores and contractures, and to help carers with moving and handling routines and things like that. And I've borrowed this from this book by Fiona, which I have referenced at the bottom there. This is just a nice little table of strategies that people can use to help with their transfer. So this can be a nice one to come back to if you're seeing a patient who's working on transfers. Okay, so that was part A, and then we come on to part B. So that was discuss some of the key evidence to support your approach and how you measure the outcome of your input. So it's over to you guys again. So the question is, name some outcome measures or objective markers you might use to measure your input when working with someone with Parkinson's. So if there's any outcome measures you're familiar with or that you've heard of that might be useful for people with Parkinson's, put them in the chat. And if there's anything else you might measure or assess, put that in the chat as well. So again, we'll give you another couple of minutes, and then Alice will feed back to me your responses.
Okay, the timer has started. So yeah, time's up and go. 10-meter walk test, Berg balance, Tonetti. Yeah, 6-minute walk test. Yeah, if your patient's quite high level, that's a good one. Visual and verbal cues. Not sure on that one. Don't know quite what you mean by that. 10 sit to stand. Yeah. Yeah. Tug. Absolutely. Yeah. Well done. Keep them coming. ADLs. Absolutely. Functional reach test. Lovely. Yeah. They reach down to, I don't know, get their socks on. Berg balance. Lindop Parkinson's assessment scale. Very good. Top marks to you. Really good. Mini best test, yes. So that's the balance test, which is a little bit higher level than the Berg balance test. So if you've got a patient who's a bit higher level, that might be good. Otherwise, the Berg balance can have a bit of a ceiling effect. But that's really good. The high mat is another one that's a kind of a level above the mini best test for even higher level patients. Good. Great. Keep them going. Anything else? We've got a few more seconds. Lovely. PDQ8, PDQ39. Yeah, a bit more of a questionnaire for you there. Brilliant. Good. Wow, should we see if that matches with your list, Fiona?
You've mentioned most of the things and a couple of things that I didn't mention. So you've done great there, everyone.
That's it. We're always learning. We're always sharing and
exactly.
learning from
I've
each
just
other.
written down. I forgot to put Tonetti on my list there.
Brilliant.
So I've broken down the outcome, and again, this list is not exhaustive. So there's probably other things that you might use as well. But I've broken them down into sort of categories, although they could cross categories, but just to give you a sort of way of looking at it, structuring it. So some patient reported measures. So I think someone mentioned the PDQ39, which is Parkinson's disease questionnaire. And then there's also a freezing of gait questionnaire. The EQ5D5L, that's a quality of life questionnaire. And then a couple of falls questionnaires. So the FESI is a falls efficacy scale, and then the Dresden Fall questionnaire. So they're quite good for capturing someone's quality of life or how their Parkinson's affects them. And then in terms of looking at gait and functional mobility, 10-meter walk, I think someone mentioned that, dynamic gait index, 6-minute walk test, timed up and go. And then balance and postural control, bird balance, mini best test, like you said, and tragus to wall measurement, that looks at posture. And then things that are looking at someone's function. So 5 times sit to stand, that would relate to their transferability. The modified Parkinson's activity scale, the unified Parkinson's disease rating scale, the UPDRS, Lindop scale, someone mentioned, thank you, and that's specific to Parkinson's, and the Bartel index. And then a little mention of goal setting. So as I mentioned earlier, you want to ask the patient what's important to them, what are their goals? And that's 2 measures that you can use to quantify someone's goal. So the GAS scale, goal attainment scale, and the therapy outcome measure. So therapy outcome measure scores different areas of the patient's life. So their participation, their quality of life, their carer's quality of life, and you score it from 1 to 5. So it's quite a nice way of looking at the person as a whole, and looking at what sort of their goals are. And it's a nice way, if they are not going to make enough progress with your input to for any of the other outcome measures to be sensitive enough, it's quite a nice way of still reflecting how your input can improve their quality of life. So again, just to give you a bit of context, the Restart PD trial that I'm working on, the outcome measures that I'm doing for patients in that study are the 10-meter walk test, the timed up and go, the mini best test, and the self-reported ones are the PDQ-39, EQ5D, and the freezing of gait questionnaire. So that's quite a sort of well-rounded, lot of outcome measures to look at the person as a whole. And now on to some of the key evidence that you might use to justify input. So there are many research articles out there about Parkinson's. So I've just given you a few of the main ones to look at. So this might be where you might start, the European Physiotherapy Guidelines for Parkinson's disease. So this is where many Parkinson's experts across Europe came together to put together clear physiotherapy guidelines. So this is a really good place to start. It provides an evidence-based approach, and it emphasises person-centred, goal-orientated care tailored to the individual, and highlights the importance of education, self-management and outcome measures like we've just discussed. Quick mention for the NICE guidelines. So there are NICE guidelines for Parkinson's, but the mention of physiotherapy is quite brief. It says that we should consider referring people with Parkinson's for physiotherapy, but it's just good to know. There was a Cochrane review in 2024. So I've put all the references and also a link for each of these articles in the slide. So when we send the slides out, you'll be able to click on the link and find these. So this Cochrane review found that many types of physical exercise could help improve movement and quality of life for people with Parkinson's. But there wasn't much evidence that one type of exercise works better than others. So they found that the sort of type of exercise is less important, but it was good for people to have training that was specific to them and specific to their needs. And then another systematic review, the positive effects of physical activity and quality of life. And this was in 2024. So they found that studies to date on the effects of physical activity suggest tangible benefits in terms of both motor symptoms and non-motor symptoms, although consensus on the best form of exercise is not currently available. So again, they found that physical activity is positive for people with Parkinson's, but weren't necessarily able to recommend a particular type of exercise. And then this meta-analysis in 2025, they found that dance was the most effective type of exercise and type of dose for exercise for people with Parkinson's. closely followed by aerobic exercise. So that sort of backs up what we were saying earlier about using rhythm and music, and also about doing high intensity aerobic exercise. And they also found that balance and gait training was important, mind-body exercise and resistance training significantly improved balance. And then this was a systematic review meta-analysis into HIIT training, high intensity training, in 2023. So this found that high intensity exercise performed in both continuous and interval modes may provide motor function benefits for people with Parkinson's. So that points to high intensity and interval training being positive, which again feeds into the sort of high intensity mode that's recommended by PD Warrior. And on that note, I'll just mention as well that the PD Warrior and LSVT Big are sort of brand names of a sort of exercise program, and they're, it could be useful to do their training, but at the same time, you don't need to be you don't need to do PD Warrior to provide high intensity exercise. So that's the brand name for one program that uses that high intensity exercise. And this is one of my favourite studies. This is in 2016, and this was forced exercise for people with Parkinson's. So the reason I like this one is because someone who liked cycling just found out by accident that their friend who has Parkinson's felt a lot better after they had cycled with them on the back of their tandem bike. And then that led to studies into this forced exercise on the tandem bike. So they did a study where they had a person without Parkinson's on the front of the tandem bike and then someone with Parkinson's on the back of the bike. And then because they were cycling fast with someone on the front of the bike, it was a sort of forced exercise. They were forced to work at high intensity. And those studies found that sort of high intensity exercise had a similar effect on the brain to levodopa. So that's really promising that high intensity exercise can have can help moderate the effects of Parkinson's. So that's really promising, and that's one of the studies that sort of led to our sort of current thinking on exercise. And then I just wanted to mention the Parkinson's audit. So the Parkinson's audit is run by Parkinson's UK, and it's UK wide, and they do it every 3 years, and they've just finished the most recent cycle last year, and the report for the Parkinson's audit is just about to come out. So every service that sees people with Parkinson's in the UK can sign up to and participate in the audit. And it helps to identify where there are gaps in care and where there is good care, and also bring together professionals. So it's definitely worth looking at when the report comes out. And also, if you're going for an interview to a service that sees people with Parkinson's, have a look at the Parkinson's audit. There's a map on the Parkinson's UK website of which services are have taken part in the audit. So you'll be able to see if the place that you're applying for has taken part, and you'll be able to see what their service is like. So you'll be able to see sort of what percentage of their caseload are people with Parkinson's and what treatments they use. So it can be a really useful source of information. And also, if you're in the future working in a service that sees Parkinson's, encourage them to take part in the Parkinson's audit for the next cycle in 2 years' time. And a mention of some other useful resources. So I said about this book. So this is Parkinson's Disease, a multidisciplinary guide to management. And this is written, one of the authors is Fiona, who invented the Lindop scale. And this is a really nice book because it actually breaks down some of the physiotherapy inputs. And there aren't that many books out there that actually describe what physios actually do. So I found that really helpful. Parkinson's UK have a really good learning hub. There's lots of free online training and online resources on there, so that's a really useful place to go to find more information. There's an excellence network run by Parkinson's UK that is split into different regions. So I guess most of you would fall into the Southeast region or the London region. So I've put a link on there. And that is a group of professionals that all work with people with Parkinson's. and they share best practice and network, so and push for improvements. So that's a useful thing to join. And then I've just added Parkinson's Foundation website as well. That's the other sort of big charity in the UK that helps people with Parkinson's. So that's another sort of useful place for information. And then I'll just finish off with this little summary. So this is a nice way to sort of summarize what we've talked about. And it's also quite a nice way to prepare for job interviews and for exams when you're doing your neuro exams. So I've done this for Parkinson's, but you could quite easily do this for any other condition that you might see as a physio. So I've broken it down in terms of what is the mechanism, what assessments you might do, what treatments you might choose, what outcome measures you might use, and then what evidence you might use to back up your approach. So this can be really useful. And then just a quick mention of interview techniques. So these are the things that have helped me when I've done job interviews. So I just thought I'd mention these. So first of all, prepare some example answers from the main conditions you're likely to see as part of the role that you're applying for. So when you're applying for a job, get the job description, read the job description, and pick out what are the things that you're going to be doing in that role. So for example, for a neuro role, you might write down the main, some example answers for Parkinson's, MS, MND, stroke, and you might prepare something like that table that I've just shown you on the previous slide. Prepare some possible questions that you might get asked and possible answers for those main things that you're going to be seeing. Take a notepad, pen and water with you. So you want to be able to sit down and write some keywords as they ask you questions, because quite often the questions will be long and might be in two parts like the one that we've just gone through. So don't be afraid to take your time and breathe, write down a few keywords and take your time to think about your answer as well. So don't be afraid to say, oh, can I just take a minute to think about it? And also bring water with you, because your mouth gets really dry when you're nervous. So I think a good interviewer will provide you with pen and paper and a glass of water, but just in case, take those things with you so that you're prepared. And give your answer in detail. So for example, for that question we've just gone through, for both parts, the interviewer might have a sort of marking criteria, and there might be 6 to 10 sort of keywords that they're, or key elements that they're looking for you to say. So make sure you put in as much detail as you can without going on about it for ages, but make sure you put in plenty of detail so you're sort of hitting all the marks that they're asking you for. Okay, so that brings me to the end of the presentation, and it's over to you guys. So if you've got any questions in the Q&A, Alice and I can have a look and answer them.
Everyone's very quiet at the moment. Taking in all your information, Fiona.
Yeah, I do appreciate that. I have packed a lot of information into that. So yeah, we'll make sure we send the slides out for anyone. And also I'm happy for anyone to reach out to me. I put my email address on there. So if anyone's got any questions, I'm happy for you to reach out to me. And I'll also quickly mention that I'm happy to do some coaching or interview practice with people if people think they would find that helpful. So again, please feel free to reach out to me if you think you'd find that helpful.
I think, you know, it's a brilliant talk, Fiona. And the only thing I would add is just to remember that we do have our PD nurses as part of our team, along with, you know, our OTs and our speech and language therapists, our psychologists, and obviously the neurologists in terms of the medication side of things. So often just think about the wider team, and they might ask you in an interview question, you know, which other professions might you work alongside to enhance your patients' optimize their living. So just remember that a PD nurse is an invaluable member of the team, I would say.
Absolutely, yeah. And it's Parkinson's is one of the things where multidisciplinary working is so important. I mean, it's important in lots of things, but especially Parkinson's, MDT working is really important, because you'll be working together with the OT, speech and language therapist, the Parkinson's nurse, and like you say, when you're working on trying to improve someone's quality of life or reducing their risk of falls, you need to be liaising with the Parkinson's nurse to look at their medications, look at their non-motor symptoms. So yeah, it's really important.
There's one question. Is there any further information regarding PD Warrior in the UK?
Yes, they do training in the UK. So if you look at the PD Warrior website, you will see what courses are coming up in the UK.
I think they sometimes run conferences, don't they, where, you know, patients and staff or clinicians come together, which is a really nice way of joint working.
Alice, there's a question in the chat from if you were asked an interview question on safe discharge planning from acute community services for a person with Parkinson's, what key points would you focus on?
Oh, that's a nice juicy question.
That is.
And unexpected. Safe discharge planning. So what are the things that they need to be able to do to be able to go home safely? So obviously there's things that you would then hand over to the community rehab team. So they don't always need to be back at baseline to go home, but they need to be safe to go home. So what are the things that they need to be able to do? So if they live on their own, they don't have any care, do they need to be able to get in and out of bed, on and off the toilet, up and down stairs, those kind of things? So look at what are the safe things they need to be able to do. If they do have carers, what are the plans that the carers need? This is where your multidisciplinary team working is really important. So you need to be liaising with the OT and the medical team, see what else they need in place to go home. And also the OT is really important. Do they need hospital bed? What equipment do they need when they go home? It's really, while we're on the note of being in hospital, it's really important that people continue their medications while they're in hospital. So if you are seeing people in an acute hospital with Parkinson's, make sure you're fighting their corner and make sure that they are still getting their medications, because we have seen cases of where people get their medications just stopped when they come into hospital, which is not good, and it can lead to serious problems. So make sure they've got access, if possible, to their Parkinson's nurse while they're in hospital and they're taking their medications. And again, once they're going home, they need to have those medications ready for them and available when they go home as well, to make sure that they can continue that. And medication routines are really important as well. So with Parkinson's medications, it's important that they're taking them as prescribed and at the right times of day. So they need to understand their medication routine and how they need to take their medications before they go home, if they're going to manage them independently. If they're not very mobile, we need to think about pressure care. So they need to have the right pressure care in place before they go home, especially if they're bed bound or chair bound. Anything else, Alice, that you can think of in terms of safe discharge planning?
I was just thinking about falls and thinking about managing the risk of falls, and perhaps you would consider doing a home visit to check that they haven't got rugs that are slippy or anything that can constitute a falls hazard that might not be on the forefront of someone's mind whilst they're in hospital, but in a home environment it's very, very different. So I would think a little bit about falls and risk of falls and environmental hazards as well.
Yeah, absolutely. Yeah, that's really important. And if they've got good family members as well that can help prepare the home environment, things like that will really help. Family can help with that, with moving furniture, taking up rugs and things like that if needed. I have had many patients over the years who do not want their rugs taken up. So just be prepared to have that, have that respectful conversation and respect people's capacity to make their own decision. But it's your job to advise them on what can minimise their risks and minimise their risk of falls where you can. And as a community physio, it's really nice to hear people talk about safe discharges, because many times I've been the one to pick up the pieces when people are not discharged safely. So it's good that people are thinking about that. Any more questions?
I can't see any more. Can anybody else see any?
Someone asking about any further information regarding PD warriors in the UK.
Oh, I think, did we answer that one? I think we did,
Yeah.
did we?
Yeah,
Did you?
again,
Okay.
so have a look at the PD Warrior website. There's loads of information on there, and they do regular courses in the UK. So yeah, have a look at that.
It's a really good course, and you can also extrapolate some of the exercises and information that they go through to other patient groups as well. So I would say it's well worth it.
And asking Fiona for your email address, if that's possible, just to contact you about the possibility of some
what I'll do is I'll
with interviews.
I'll put it in the chat. I have put it on the slides anyway, but I'll put it in the chat as well so that people have it.
We've had another question come in saying, thank you for the session. Can I ask if you would prefer PD patients taking their medication before your treatment and assessment session or not?
That is a really good question. I think ask the patient what their routine is and when their best time of day is. So if, for example, if they were coming to see you in clinic to do exercise, or they were coming to an exercise class, you really want to see them when they're on their medications, really. So it's not always possible with scheduling, but if you can schedule it for their best time of day, that would work the best. So you need to ask them what time of day they are best. It might be half an hour before, half an hour after they've taken their medications, or an hour after they've taken their medications. It might be half an hour after their second dose of the day. So ask them what time of day they're best. And that's probably, if you're doing exercise interventions, that's probably the best time of day to see them if you can. Like I said, if you're working on a particular function, you might want to see them at a time when they're off. If you were looking at being able to get out of bed when they're off, but usually you'd want them when they're on. So yeah, you'd probably prefer for them to take it before. And like I said, they usually have to take it at a very specific time of day. So they might even literally have on their prescription, you take this at 9 o'clock, you take this at 11 o'clock. So it will be very prescribed what time of day they take their medications, and you might have to work around that if you possibly can. Another important note with medications is make sure people read their medication leaflet and take it as prescribed, and also check how they need to time around meals, because levodopa usually needs to be taken not with protein, so usually not when you're eating, which is counterintuitive, isn't it? Because a lot of medications you take with food. So most levodopa, it says it advises to take it 30 minutes before you eat, or at least 30 minutes before you eat any protein, because it can slow the absorption. So just we're not pharmacists, it's not our job to give advice about medications, but just make sure they know their medications and that they're taking it as prescribed, and that they've read how they need to time it around meal times. And we talked about constipation earlier, so if someone's constipated, that can slow down the absorption of their medications as well. So if someone is sort of struggling with their motor symptoms, check that they're taking their medication as prescribed, and check if they're constipated, and then if they are, speak to their GP or the Parkinson's nurse. Anything else to add about medications, Alice?
The only thing I was going to say is that I completely agree that if we're doing an exercise intervention, then ideally, yes, we want them on their on phase. But sometimes I have had requests from carers, for example, that towards the end of the day, it's really difficult then to, for example, get them from the sofa into their wheelchair to move them through into their bedroom for bedtime. So it might be at that point that you might think about doing a joint session with the carers, or thinking about changing the time of the medication a little bit. So that's where you would link in with your PD nurse as well and talk about what solutions can we come up to this problem. So it really is about joint working and seeing if you can work out the best route forward for the patient.
Yeah, that's a good point. And I've quite often had, when I'm working on an inpatient setting, and you probably experience as well, I quite often have a patient who I go and see them during the day and they're really good and they get out of bed and they transfer and walk them to the dining room or something. And then the carer will say to you, well, they do that for you during the day, but when I try to get them up in the evening, they can't do it. So yeah, it's important to think about the variability, isn't it, of symptoms. So yeah, if someone needs you to work on those functional things when they're off, you might want to see them while they're off. And also they might need a variable care plan, mightn't they? Like moving and handling plan. They might mobilize while they're on, and then they might need a stand aid or assistance when they're off.
Yeah, absolutely.
Thank you both so much for your time tonight. And just to say to everyone on the call, have a look at the graduate support package that the CSP has produced to support you. It's really good if you're in your final year as well to start having a look at what's on offer. Fiona, would you mind just popping to the next slide?
Yeah.
And then if we could just ask you before you go, just to think about signing up for your the session we have coming up next week, which is we've got some fairly new graduates talking about how they got their first role. So do have a look to sign up. And Amelia, do we have a feedback QR code for this one as well?
Yeah, it's just the next slide.
Next slide. Thank you, Fiona. You don't, that's it. Lovely. So if you, just before you disappear off, we'd love you to just provide us with a little bit of feedback. And thank you for the suggestion in the chat for maybe a session on physiotherapy in the community with mental health patients. So we'll have a look at seeing if we can access anybody in the region that might be willing to do a session on that. So leave that one with us, and thank you for that suggestion. Otherwise, just a huge thank you to Fiona and Alice for giving up their time tonight. It's massively appreciated that they both have done this for us all tonight. Please do take a look at the other webinar recordings that we have on the South East Coast Regional Network if you've missed them in the past. And the PowerPoints are on there as well if you want to use them as an aid memoir when you're going for any interviews and things like that. But otherwise, have a lovely evening, everybody, and hopefully we'll see you next week on the 18th for the final one in our series so far. But we haven't forgotten about the mental health request, so we will look into doing that one. Thanks, everyone.